Hello, and welcome to the Asthma and Allergy Foundation of America's latest education program titled Understanding Nasal Polyps Part 3, Biologic Treatment Options. This video is the third in a series called Patient-Centered Education and Care for Nasal Polyps, or PCENP. The overall goal of PCENP is to support people with nasal polyps and improve the patient-clinical partnership in managing and treating nasal polyps. My name is Jay Norris. I'm the Mission Program Administrator here at the Asthma and Allergy Foundation of America, and I'll be your host today. I would like to reintroduce you to our speakers that we had in our previous workshop as well. They'll be helping us with Workshop 3, Doctors Tanya Laidlaw and Dr. Kathleen Buchheit. Dr. Tanya Laidlaw is an Associate Professor of Medicine, and Dr. Kathleen Buchheit is an Assistant Professor of Medicine, both at Harvard Medical School in the Division of Allergy and Clinical Immunology at Brigham and Women's Hospital. Dr. Laidlaw, Dr. Buchheit, thank you both for being with us again today.
Happy to be here.
Thank you.
Please take a moment to review our disclosures. Okay, now what will we consider in today's workshop? We'll do an overview of biologics, discussing what they are and who is a candidate for biologics, and we'll also discuss what biologics are currently approved for treating nasal polyps. Again, if you would like to review our previous workshops, please visit aafa.org/NPS. And I would like to pass it off for our discussion starter. Biologics, what are they?
So let's just start with the basics. What does it mean to be a biologic medication? What do we say when we refer to that class of medications? So these are relatively newer treatments, at least for the fields of respiratory medicine and for nasal polyps. And they're made to target super specifically just one molecule or one area of the immune system that might drive inflammation or might drive inflammation in a particular patient. So depending on the biologic, these are ones that have been shown that they can improve symptoms or decrease polyps and actually decrease inflammation. And can really act as a treatment for patients who even have very severe nasal polyps. Some of the biologics can also treat other diseases that you might have at the same time. Many patients with nasal polyps also have asthma, and those are often called comorbid conditions at the same time. And so one medication, one biologic, might be able to treat both diseases at the same time. At the moment, all of the biologics that we have available in the US to treat nasal polyps are given as injections, as shots. It's possible in the distant future there would be other ways to do them, but for right now, we're stuck with using them as shots. And at the moment, none of the ones that we have available in the US to treat nasal polyps have been shown to truly be a cure, right? So they work as a long-term treatment. You can be on them for a very long period of time and they continue to work. But upon stopping the biologic treatment, the nasal polyps eventually and the symptoms will come back. So how are they given? Again, I mentioned so far all we have right now are given as injection. And Dr. Buchheit in the future, in a few slides, will go through some of the details of how we give them. And usually these are given either at home when you're taught how to do them on your own after some nursing teaching or some healthcare provider teaching for how to do that when you're comfortable. And many of them can be given at a doctor's office or at a clinic or at an infusion center. And we'll talk a bit about the biologics specifically and which ones are given where. So who is a candidate? Which patients, which people do we think might be sort of best suited to trying a biologic? So really, it's meant for patients who have ongoing symptoms and ongoing problems with their polyps, despite doing all the other things that we've talked about. So, the good standard care, the good medical care is always going to be our primary thing that we start with. And it's when that, good medical care, good standard of care kind of fails, isn't good enough. So your symptoms are still severe or they're long lasting, even with all the standard medical treatments. And in part 2 of these series, we talked about nasal rinses, sinus rinses, intranasal steroids, and a few other medical options. So if those, quote, fail, you're trying them properly for a good period of time and they just aren't working, you might be stuck with trying to move on to trying a biologic. There are also patients who might have more than one disease at the same time that would be treated well with a biologic. Severe asthma, severe eczema, and something called eosinophilic esophagitis, or EOE for short, are 3 examples of things that sometimes coexist with patients with polyps. And it might be that one biologic has actually been tested and proven to work well for both of those diseases. And therefore you can the phrase is to kill 2 birds with 1 stone by using the right biologic. And then, often for polyp patients, it's that patients not only have failed their standard medical therapy, but have also gone to a good surgery, had a good sinus surgery. And unfortunately, despite all of that, their nasal polyps returned after sinus surgery, so their symptoms are back, and then we're frustrated, might want to go to a biologic for those patients as well. So, what role does inflammation play in this disease? Like, why are we inhibiting inflammation with a biologic? Because we think that nasal polyps are largely driven by some kind of inflammation. And there are other conditions that are also often driven by inflammation, maybe even the same kind of inflammation. So, in our little circles at the bottom are other things that might coexist in the same patient. So, nasal polyps and asthma, and prurigo nodularis, a skin disorder, atopic dermatitis, another phrase for eczema, food allergy, or eosinophilic esophagitis. And those are all other conditions where there's a single biologic, or perhaps more than one in some cases, that's approved to treat both nasal polyps and one of these. So that, in the future, we start talking about which biologic might be right for you. Well, if you have one of these conditions and there's only one biologic that also treats one of these conditions and polyps, then we might recommend that one. And overall, the biologics work by disrupting either a cell pathway or a specific molecule that sort of triggers or continues the inflammation. And we want to stop that in order to stop the inflammation from becoming chronic, from really setting in and lasting for a long time. So what are the possible benefits of biologics? So overall, we use them for nasal polyps because it can help shrink nasal polyps so you get much less swelling and fewer symptoms over time. So less sense of congestion, more easily breathing through your nose. For patients who have lost their sense of smell or taste or have decreased sense of smell, many times biologics can actually bring back the sense of smell or bring back it partially. It can help to decrease the number of days that you have flare-ups or symptoms overall. And it can really reduce the need for oral corticosteroid pills like prednisone that have so many side effects. We do work very hard to try to avoid overusing those medications. It can help patients who have gone through surgery but need further medical treatments to help reduce symptoms even despite surgery. Or for patients who have already had multiple surgeries and their polyps have regrown, starting a biologic can then decrease the chances for needing a specific additional sinus surgery after that. And for patients who have polyps and also have asthma or the condition called aspirin-exacerbated respiratory disease, AERD, the use of a biologic can not only help the polyps, but often help asthma as well. So not every patient is going to get the same benefit or the same side effects or the same treatment effect. So everyone responds to treatments differently. So you're going to have to work with your provider and work with your team to talk through the biologics that are available, which one would be best for you, and how you're going to together track your progress to see if they're working for you over time. So what are the potential side effects of biologics? So, the short answer is it really depends on the biologic that we choose for each patient. In the little blue circle, sort of a little reaction where the biologic is injected is the one thing that all biologics share. Anytime you inject anything into the skin, you run the risk of having a little local reaction, some itching, some bump, a little bit of rash there. But several of the biologics have also been found occasionally to cause other side effects: headache, sore throat, fatigue, joint pain, or skin rash. And again, depending on the biologic that's chosen for you, you might have more or less of this side effect potentially show up for you. So overall, the biologics we have right now that are FDA approved for polyps are really safe, and they do work well for many patients. So even though we recommend these for lots of our patients, we're so excited that we now have them available for our patients. It is the kind of thing that you want to talk carefully about, talk it through with your providers, because side effects are possible, as is true for any medication that we prescribe. And so as these are relatively new, there are ongoing studies sort of constantly looking to make sure that the safety that we've seen so far is going to hold true in the future as well. So I'll pass over to Dr. Buchheit to kind of talk through the available biologics we have right now.
Great, thank you so much. So right now there are 4 biologics that are approved for treatment of nasal polyps listed here. And I think there are, a couple important things to kind of call out just to kind of know some differences between them. Dupilumab and tezepelumab, which was actually very recently approved just this past fall, are both approved for adolescents, so ages 12 and up, whereas omalizumab and mepolizumab are only approved for adults, so 18 and up. They're all given as subcutaneous injections, and we'll talk a lot more about kind of the nitty-gritty detail of what that means. Dupilumab can only be given at home, whereas the others can be given at clinic or home, and that can depend on, patient preference and insurance and a variety of other things as to where the medicine's given. They're given either every 2 weeks or every 4 weeks, and they target different molecules that are important in the inflammatory cascade that leads to nasal polyps. I want to highlight the piece at the bottom, which is other approved indications. This can be really important for an individual patient in determining which biologic to choose if you have any of these comorbidities. So, for example, Dupilumab is approved for eczema, eosinophilic esophagitis, the prurigo nodularis, bullous pemphigoid. Those are really kind of unique to Dupilumab. So if you have one of those things, you might want to choose one medication that works for multiple problems. Actually, all 4 of them are approved for asthma. Omalizumab we use for food allergy, chronic spontaneous urticaria. Mepolizumab is also approved for COPD and several eosinophilic diseases, something called EGPA, which is a vasculitis, and then something else called hypereosinophilic syndrome. So, we can consider these biologics in patients who have those comorbidities if needed. So, Dupilumab is a subcutaneous injection that's given every 2 weeks for treatment of nasal polyps. Usually at home, patients give it as an auto-injector, but can also be delivered as a prefilled syringe. And it can inhibit multiple inflammatory cells and pathways, and has a variety of other indications that it is approved for. Omalizumab is a biologic that targets something called IgE, which is your allergic antibody. Again, this one is given as an injection either in clinic or at home every 2 or 4 weeks, and the dose actually depends on your baseline, meaning before you start the biologic, weight and blood IgE level. It's also available as an autoinjector or prefilled syringe, and has approval for a couple of other indications as well, including asthma, chronic spontaneous urticaria, and food allergy. It has an important but really rare side effect of having allergic reactions or anaphylaxis to the medication itself. So for the first several doses, they're usually given in clinic to monitor for any allergic reactions such as anaphylaxis. But for patients who do well after the first several doses in clinic, they are able to transition to giving the drug to themselves at home. But we require generally that all patients carry an epinephrine autoinjector after their injections and even when they're taking it home due to this small risk of anaphylaxis. Mepolizumab is another biologic approved for treatment of nasal polyps. This targets something called interleukin-5, which is another inflammatory protein. And it can be given at home or in clinic as a subcutaneous injection every 4 weeks. It can target an inflammatory cell that's important in allergies and asthma called eosinophils. And it's approved for other indications, including asthma, COPD, EGPA, which is vasculitis, and hypereosinophilic syndrome. And then lastly, tezepelumab is the most recent biologic to be approved for treatment of nasal polyps. And this targets something called thymic stromal-lymphopoietin, or TSLP for short. And this one is given as an injection every 4 weeks in clinic or at home. And it can also be administered as an auto-injector or prefilled syringe. And it can target multiple inflammatory pathways and is approved for asthma as well. And now I'll pass it back over to Dr. Laidlaw, who's going to give some practical advice about the roadmap to getting a biologic.
Thank you. So these are relatively complicated medications, both to prescribe and to receive. And so we're sort of going to walk through what this might feel like from the beginning to the end in terms of deciding which one to use and then what steps you'll end up going through before you can actually get it. So very rarely in this sort of roadmap will a primary care physician or a generalist be prescribing a biologic for something like nasal polyps. These will almost always happen after a referral to a specialist. And for patients with nasal polyps, it's usually going to be either an allergist who's treating nasal polyps or a rhinologist or an otolaryngologist who's treating nasal polyps. If your disease also involves asthma, you might have a pulmonologist who's comfortable prescribing biologics as well. And then depending on the biologic, there are usually some labs or tests, usually a blood draw, that they might want to do before they prescribe the biologic. The most common one that we see done are actually two. One is a total IgE level, just as Dr. Buchheit mentioned, that's the sort of allergy antibody. And if they're considering using omalizumab, they want to know what that level is. They can target the right amount of medication to the right level of the IgE. And the other one is something that's for short called a CBC and differential, but what it really stands for is a complete blood count with differential. And it's a quick blood draw where they are able to count the number of certain kinds of cells in your blood. And we're often specifically looking for that number of eosinophils Dr. Buchheit mentioned. So everyone normally has eosinophils in their blood, but very high levels of eosinophils are more associated with certain allergic syndromes, things like allergic asthma, certain kinds of nasal polyps, and other allergic diseases as well. So we usually want to know sort of where that level is before you start. So then we would make sure that the patient we want to prescribe the drug for has a specialty pharmacy. And we'll talk about that a little bit more as well, and confirm what their insurance will or will not cover. So most insurances in the United States will cover these medications when appropriate, but there are often certain kind of clinical criteria, like how severe is the patient, that we need to sort of confirm for the insurance that it's the right next step for our patients to take. And for many patients, neither the patient nor the prescribing doctor actually has a choice about which specialty pharmacy to use. That's often a choice that's already been made for you by your health insurance company. Then the biologic is prescribed. Ideally, the insurance company approves it, and the specialty pharmacy then ships it out to you or ships it out to the clinic, depending. And either you pick it up and bring it into the clinic for teaching, or it's already shipped to the clinic. And there's usually at least one visit, either with a clinician in person, or sometimes it's done online, to train you, right? The sort of the act of giving yourself a shot is often quite foreign to patients. And we'll walk through some steps about what that feels like. So what's the role of the pharmacy here? This usually isn't picked up at just a regular outpatient pharmacy. Many of the outpatient pharmacies also have associated specialty pharmacies, but rarely do you just kind of walk into your pharmacy like you would for a regular prescription to pick it up. It's often something that's either shipped to you or shipped directly to your clinic. And if it's going to be shipped directly to you, often the specialty pharmacy will actually call you to make sure you're going to be home when it's shipped, because we don't want it sitting in your front porch for weeks on time when you're on vacation. And so we often will warn our patients, you start to memorize your specialty pharmacy phone numbers so that you make sure you pick it up every month, so they know to ship it out at the timing that's going to work for you. So in terms of health insurance, depending on how much is covered, if you have full coverage, that's amazing. If not, there's often an additional copay or a specialty pharmacy copay. And many of the companies that produce these biologics for us do have financial assistance programs where they can help to offset some of the cost if needed. And this is really helpful at the beginning to talk it over with your healthcare team that's going to be prescribing these, and really to confirm that your insurance coverage will be solid for that particular biologic, for the particular indication, what's called nasal polyps, that you have. So in terms of financial assistance programs, those are often run through the drug manufacturer themselves, sometimes through the specialty pharmacy, and occasionally through your own personal insurance. And there's a website there through AAFA with more information available. But once you get to the point where you know what medication, what biologic is going to be prescribed for you, that's a time that you can often reach out to your own health insurance provider to confirm what their coverage for that biologic is going to look like for you. So prior authorization, this is something that's often referred to as a PA. And this is really like an extra layer of work to try to get the biologic covered. So what happens from our perspective when I'm prescribing it is I have a long conversation with my patient, we discuss it, I write a long note that describes it, and I prescribe the medication because clearly we've thought long and hard that this is the right thing for you. So I'm sort of authorizing it by prescribing it. The insurance company looks at it and they say, we want one more check to make sure that you really meant it. And they come back to my office and they say, we need this additional piece of paperwork that's called a PA, a prior authorization. So before we give out the medication, prior to that, we want additional authorization from you. Usually this is something that the office, the medical office, kind of do behind the patient's back. It doesn't necessarily involve the patient getting in there. But often patients will get calls from their insurance saying, oh, we are waiting for the PA or waiting for the prior authorization, while our office then has to work to make sure that this extra layer of paperwork is done properly for you. So this is a time where you're going to have to be your own advocate. Sometimes you're working with a healthcare provider team that has a lot of experience with prescribing biologics, and they sort of have like a well-oiled machine for how to help get it done. And other times, or every time there's a new biologic, we're all working together to try to figure out how to do it the best way for each one of our patients. So this is going to have to be a time where you get to be as educated as possible, and you're going to end up having some back and forth discussions, often with your doctor or with their office, with your own health insurance and with your specialty pharmacy. And then to make sure that depending on what biologic you're on, that you have the appropriate number of appointments to either get the biologic in clinic or to have follow-ups for that once you start it. And to make sure that your prescribing team is aware of any insurance changes, so the specialty pharmacy can also be updated with that new information. So I'm going to pass it back to Dr. Buchheit to go through some more practical tips for how we actually get these and use these.
Great, thank you. So, first thing, once you get the medication delivered to you, you kind of, want to think about storing it in the refrigerator. But once you're on it, they're going to continuously send you new prescriptions every month. So, it can be helpful to, about a week or so before your dose is set to be given, check to make sure that the delivery is on its way. And you'll often hear from the specialty pharmacy to contact you to authorize the delivery and say, yes, I'm going to be home. I will accept this delivery. So make sure you do that. Then, it can be helpful to put in a calendar reminder about the date that the dose is due. And when you're going to administer it, you want to remove from the refrigerator and kind of check the medicine before you administer it. Generally, we tell people to remove it from the refrigerator about an hour before they are going to take it, because it is much more comfortable to do the injection if you let it come up to room temperature first. So that's an important part of the process. And then after you've given yourself the dose, you want to make sure that the next dose is on your calendar for either 2 or 4 weeks in the future, and that kind of the reminders are set. And some people do find it helpful to set a reminder, a week before the dose is due, again, to make sure that they have connected with the specialty pharmacy and that the next dose is on its way. So in terms of training for self-injections, as Dr. Laidlaw mentioned, it can be really helpful for some patients to have an appointment with the nurse or pharmacist to go through the process. There are also really good video resources that are generally available online. The pharmacy can sometimes send you some of these where they can walk you through the injection process and kind of remind you of the little details that when you start may forget or feel a little bit overwhelmed by. There are also trainer devices, so practice devices that you can use that have no needle or drug, but just give you the feel of what the injection itself is going to feel like. Practically, you should have a sharps container. Sometimes these are sent from the specialty pharmacy with the first dose. If not, you can actually get one usually from a regular commercial pharmacy. You can sometimes get them, you can order them online. And you should connect with your local health authorities or kind of garbage removal authorities about kind of determining the best way to dispose of these sharps containers, because you don't want to put anyone else's safety at risk with accidental needle sticks. So make sure to be a good citizen and check in and do that. If you don't have a sharps container, you can sometimes collect the devices and bring them with you to a doctor's appointment to dispose of them there, although, in moderation, because it can get overwhelming in the doctor's office sharps containers. And then a lot of my patients find it really helpful to have a support person get trained with them. Having a second set of eyes and ears, hear the whole spiel about exactly what you're supposed to do can be really reassuring, and nice to have a partner that's kind of with you in the journey of the injections as you're getting used to it. So some tips for self-injections. Especially as you're getting started, it can be helpful to kind of set up everything you're going to need while the medicine is coming up to room temperature. So that will be stuff like having your sharps container ready, having alcohol wipes ready that you're going to clean the area with first, sometimes having a little gauze pad or Band-Aid that you're going to use at the injection site after you're done injecting. Having that all laid out can be really helpful. We tell our patients to rotate the injection site. So typically when patients are self-injecting, they can inject in the abdomen or the upper outer thigh. If you have a family member injecting, you can also do it in your upper arm. But going back and forth between sites can be a little bit more comfortable. Injecting in the same place over and over again can cause some, irritation, sometimes skin changes in that area. This is really important. This is a press and hold technique. It is not a stab. these biologic medications are thick, they are viscous. And this can be surprising to some patients that it can take some time, like 20 or 30 seconds, for the dose to fully inject. So when you press down on the medication, you're just going to hold it there and you're going to watch the syringe plunger go down until the medicine is fully injected. And then usually with the auto injectors, you hear a click. That's a signal it is all done. If you press down and pull right back out, most of the medicine will spray around the room and not get into your body where you need it, which is really, it's happened to a lot of people. So just, mentally prepare yourself that you're going to inject and hold the first time. And unlike the epinephrine auto injectors, they're not designed to be injected through clothes. You're never going to use these in an emergency. This is something that you can carefully plan when you're going to do. So you want to thoroughly clean the area with alcohol in advance and then do the injection without clothes covering that area. So in terms of how to store the biologic, it's helpful to have some dedicated refrigerator storage space, make sure that the refrigerator temperature is appropriate, and the biologics come with information about exactly the storage temperature. So follow the manufacturer's instructions. You don't want to place them in the door really close to cooling elements. You don't want them to freeze or get too warm. And then you can set a reminder to remove from the refrigerator about an hour before the injection. And we'll talk about this in a few slides when we talk about traveling. It's important to kind of check with the pharmacy to determine how long it is safe to leave the biologic at room temperature. For many of them, you can actually take them out for several days or even a few weeks before injecting and leaving them at room temperature. We do not recommend taking them out, letting them come to room temperature and putting them back in the refrigerator. But if you know you're going away, you can take the biologic out and put it in your bag, travel with it, and then inject it several days later. But it's important to check with the pharmacy about how many days you can do that for. You should check the medicine before using it. Make sure it's not cloudy or chunky or looks funny. And then also check the expiration date to make sure that it has not expired. And then, this is an important question that we get asked by our patients a lot. Can I travel with my medication? And the answer is yes. Yes, you can. If you are going to be going on a long trip, and you need to take several doses with you, if you have several doses that you need to take with you, you can put them into a cooler bag and carry them onto the plane with you. Sometimes patients request letters for this, that it's safe to, but if you have the prescription for it, it is generally fine. If you're going on a shorter trip, like a weekend away, many of the biologics that are approved for nasal polyps can be taken out and left at room temperature for several days or even weeks. So you can store them at room temperature, and then, if your date to inject is 3 or 4 days later, potentially inject. But again, check with your pharmacy about how long you can leave it at room temperature. Again, once you've taken it out and let it come to room temperature, don't put it back in the fridge when you get to your destination. Just leave it there if that is your plan to use it that way. And then when to call your doctor, if you forget or miss any doses, if you make a mistake doing the injection and you accidentally pull it in, pull it out, the full dose doesn't get injected, let your doctor know, they'll help you. If you're sick and not feeling well, especially if you're having like an asthma exacerbation on the day of the infusion or injection, you might want to let your doctor know. Or if you're having any side effects you're concerned about that aren't going away, please reach out. And then in terms of follow-up, you'll set the follow-up plan with your healthcare team, but you have to remember that you do need to have regular follow-up while you're on these medications. And that should be really kind of part of the plan going forward. That is often going to be required by insurance because they want to make sure that you're doing well on the medication if they're going to continue to fill it for you. You'll also, follow up with your specialty pharmacy, and then, using calendars to track your treatment schedule can be helpful as well.
So in terms of some of the common questions and like other workshops we might go through, we get a lot of questions about biologics. And I think going through these and kind of have a sense of how we answer them and how we discuss these with our patients can be really helpful. So one thing is, are we going to consider using biologic medications like before sinus surgery or after sinus surgery? And the answer, frankly, for most of these is like, it depends. It depends on the biologic, it depends on the patient. So very rarely would we recommend, or like when a patient comes to me with bad nasal polyps, and the first thing off the bat I'm going to say is, let's try a biologic. That's not usually how we start. Usually we have standard medications we go through. We went through in the part 2 of this series. And for most of our nasal polyp patients, we're going to recommend that they have one good thorough sinus surgery as well before we would consider starting a biologic. Now, there are a couple of exceptions to that. Mostly it has to do with comorbidities. So if you're a patient who does have nasal polyps, but you also have, severe uncontrolled eosinophilic esophagitis or severe uncontrolled asthma, and I can kind of tell that you're going to need a biologic for those other comorbid conditions anyway, and you really don't want to go through surgery, maybe we can just start the biologic without surgery. But the vast majority of our patients are going to want to go through one super good sinus surgery before we start a biologic. And I don't know, Katie, about using biologics after surgery. Again, I hate to say it, but it sort of depends on the patient. Sometimes, yeah, we do continue them after surgery.
Yeah, I mean, I would say that in general, sort of that primary surgery has a lot of benefits, regardless of whether or not you start a biologic potentially, but that really close follow up with your otolaryngologist and your allergist or pulmonologist after surgery can be very helpful, because if symptoms are recurring quickly after surgery, I think that there is potentially a role for using biologics, and that's really kind of how we think about using them most frequently as someone who's had surgery and then all of a sudden their symptoms or polyps came back, and we don't necessarily think that doing another surgery is going to provide long-term benefit.
Yeah, that makes sense. So in terms of the question of how long am I going to have to use this biologic for? So, as we talked about earlier, at the moment, for the 4 that we have that Dr. Buchheit went into the detail for, none of those have been shown to be a cure, right? So they work when you're on them, but after you stop them, after a few weeks or a few months, the symptoms all start to recur, the polyps start to come back. So at the moment, the answer is you're going to have to be on them for as long as you want to get the benefit for the biologic. Now, that being said, this isn't a scenario where you're going to get reprimanded for stopping them, or there's something dangerous about stopping them. So that if for whatever reason you start a biologic and it either is or isn't working, but you choose to stop it, you want to stop it, is it because you're moving? Is it because you lose insurance? Is it because you just decide you're not interested in doing the injections anymore? Whatever it is, please let your provider team know. But you can stop them if you want to as well. There's no need to continue them. You just have to know that the symptoms will come back once you stop them. In terms of how quickly symptoms improve once you start a biologic, so there are some patients where after that very first injection, within a couple of weeks, they already start to notice improvement. Improved sense of smell, decreased nasal polyp kind of symptoms, less congestion. They really start to feel better just after that first shot. And those are the patients that we're so excited for them. In general, I'm curious, Dr. Buchheit, how you discuss this. It looks both from the large clinical trials that were done for these, but also in my clinical experience, that if you haven't gotten any benefit after 3 months of a biologic, it's probably not going to be one that works for you. And so I usually won't, I'll sort of do a check-in at 3 months. And if we're not getting much at all, maybe I'll push it to 6 months. But if you're not getting benefit by 6 months, we're probably going to call it and try a different biologic at that point. How do you approach that?
Yeah, I have a similar approach. For patients where we're really struggling, I will push it out and have them do a full 6-month trial. I would say that for the vast majority of patients, we know within a month or 2 if it's going to work. But there are kind of some slower to improve folks out there where I do think that doing a sort of full 3 to 6 month trial makes sense.
Yeah. So, what if I'm afraid of giving myself shots is a perfectly appropriate question. And my only general advice is don't feel like a wimp about it. I can never predict which ones of my patients are going to be this is fine, no worries, or are going to be, super wimped out about it and afraid of it. It's something I try to walk my patients through and give extra, help about that. I do have lots of patients who really want to do them at home, but just can't bring themselves to do it. And they'll find a neighbor or a friend who's in the healthcare world, often a nurse down the street who's willing to come over after work and do them for you. But I would also encourage you to try different parts of the body. I find that patients have very strong feelings about the upper arm versus the abdomen versus the thigh. And from our perspective, I don't care. Any of those places is equivalent from how well the medication works. But if you feel like the abdomen is, much easier for you and much less painful and never want to use the leg, totally fine, or vice versa. We also find that, all of the 4 biologics that Dr. Buchheit went through come as what's called a syringe or an auto-injector. And there are pros and cons to both of those. And people generally, I think, will prefer the auto-injector because it's sort of easier. You just take off the tip, hold it against your thigh or your abdomen, press and hold. Usually means you're counting to 10 slowly while it injects, and then it clicks and you let it go. That's easy, right? You don't do a whole lot. On the downside, you can do it wrong the way Dr. Buchheit suggested. So if you get nervous and you sort of like go in and then pull right out again and it squirts all over the floor, that's disappointing. It also is, it's a device where the device does the work for you, which means that you have a little less control over it. So I do have patients who actually think that the pre-filled syringes are more comfortable because they can decide how quickly it goes in and how quickly it doesn't go in. So if they want to try to push as hard as possible and just get it over with, that's fine. Or do a much more slow kind of push and it's less painful, also fine. So that's an area where like you get to kind of choose what feels better to you. Do you have any like other tips for patients who are afraid of this idea?
What I'd add to that is that, I have had patients who have really, for a variety of reasons, much more convenient, wanted to do at-home injections, but due to being unable to inject themselves, have elected to do in-clinic administration. So if that's like feasible, again, from sort of a life insurance standpoint, and otherwise you would never consider in a million years self-injecting, talk to your doctor about that and be upfront about it, because the prescriber will want to kind of think about options that can be delivered in clinic, and that is preferable to some patients for sure.
Yeah, that's a good point. So the next question about, do biologics decrease the need for surgery? So I would say if the biologic is working for your polyps, yes, overall they decrease the need for surgery. So all 4 of those biologics have been tested, right? Have been trials and large trials with hundreds of patients. And all 4 of them were tested in patients who had polyps on both sides already. And so they have all been proven to work to decrease those polyps. It doesn't mean that every biologic will work in every patient, but kind of the point is to help decrease the need to have those polyps taken out. And in terms of whether or not they help you regain their sense of smell. So most of the biologics that are out there for nasal polyps have been shown to improve smell in some patients, not in everyone. We can't predict for sure that a particular biologic will work for you or that your sense of smell will come back. One kind of trick that we use, which is not fully tested, it's more just, it seems to work with our patients, is that if you have a decreased or no sense of smell now, if you remember back to the last time you ever used any oral steroid, like prednisone, if you remember that prednisone, that steroid course brought back your sense of smell, or at least improved your sense of smell, even temporarily, we kind of like know the machinery is still working. For those patients, often we can get some sense of smell back with one of the biologics. On the flip side, unfortunately, there are some patients where even when they were on like high doses of prednisone in the last year, when they really think about it, they still couldn't smell anything at all. For those patients, I'm a little bit less encouraged that the biologics will be able to bring back your sense of smell. Dr. Buchheit, do you feel the same? Was that how you talk about it with your patients too?
Yeah, generally. Although, I have had the experience. I think there's a little bit of data suggesting that there are some folks that either might not remember with oral steroids or weren't maybe on a high enough dose or on it for long enough to get their smell back, who do have or at least some improvement in sense of smell on biologic therapy. So it's not, I don't think, a totally hopeless situation, but I think it's a really good kind of marker for, are the olfactory nerves working? Are you able to smell?
Right. And then finally, like, how often should you follow up with the prescriber? So I would say, out of respect to the prescriber, you should probably ask them as they're prescribing it, how often do you want me to follow up with you? I will say that the absolute minimum is once a year, right? So if I'm going to re-prescribe a biologic medication for you, I can't do that if I haven't seen you in the last year, because your insurance will not cover it. So that's the absolute bare minimum. Usually when I'm starting a biologic, I like to see my patients every 3 months, a couple times, like 3 months, 6 months in. And then if we're happy and things are going okay, then we can go to every 6 months and then maybe once a year. But for most of these patients, at least in the beginning, I want every 3 to 6 months. And then we can sort of move from there depending on what you need. So thank you so much. These are things that we get all the time from our patients, and I'm hopeful that the discussion and the answering back and forth has been helpful.
Thank you, Dr. Laidlaw and Dr. Buchheit, for that question and answer, and for reviewing the biologics as a whole. It's been great working with both of you on this workshop. We're excited to talk about what we'll have in future workshops. We'll discuss surgical options for removing nasal polyps. We'll continue to talk about navigating nasal polyps and related chronic conditions, practical tips for managing nasal polyps, holistic health approaches, and more subjects. Again, thank you all for joining us for this workshop. We would also like to thank Sanofi and Regeneron for their support of this educational program. All content was developed by AAFA independently and the speakers. Thank you for joining us, and we'll see you again.